Hi everyone, welcome back to another basic module in infectious diseases. Today we have on board Dr. Swati S. Dupat. She's a passionate clinical pharmacist with core interest in PKPD aspects of antimicrobials. She is currently doing a fellowship in infectious diseases. Also, she have done various studies regarding the treatment regimen of carbapenem-resistant enterobacterias and tedium of some antifungals like posaconazole, isavuconazole, etc. And recently, she has spoke in CP Summit 2024. We are very proud of it. And here today, she will be discussing on clinically significant adverse events of antimicrobials. So, without much delay, let me invite Dr. Surabhi. Over to you, Surabhi.
Thank you so much for kind introduction, Dr. Elena. So let's start the presentation without wasting the time. So my topic today is clinically significant adverse effect of antimicrobials, and as we all know, the theoretical aspects of it, as we all know the definition of adverse effect, we are directly moving towards the case-based approach. So we are starting directly the cases. So there is no disclosure from my point of view. So we are going to start our case one. So case one is of 43-year male with a known history of or a known case of hypertension, and he was on nifedipine for that. He was presented outside clinic with the complaints of cough, fever since 1 month and a weight loss of 2 to 3 kg within that 1 month, and he was treated as a community acquired pneumonia with multiple antibiotics such as azithromycin, doxycycline, etc. But later, then he came to us with a persistent fever in August, 14th August 2024. We investigated him and we found that his CT chest shows a patchy consolidation in a left lower lobe with the surrounding ground glass densities and few mediastinal lymph nodes with a pericardial minimal effusion. While his sputum culture had grown Pseudomonas aeruginosa, which was pan-sensitive and for which he was started on ceftazidime. His BAL gene expert had shown MTB, that is Mycobacterium tuberculosis, was detected with reef resistance was not detected. And his baseline LFTs, which was done on same day of admission, were in normal levels. So we did started him on normal weight-based AKT on 20th August after the gene expert report, and with the doses of isoniazid 300 mg, rifampicin 600 mg, pyrazinamide 1500, and the ethambutol was 1 gram. After starting the AKT, he developed a transaminitis as well as increased in bilirubin, which showed the hepatic derangement after the 7 days of starting AKT. 7 to 8 days. So on a 27th of August, he developed a hepatic derangement. So this is his BAL gene expert report, which showing you the Mycobacterium tuberculosis was detected, but rifampicin resistance was not detected. His sputum culture had showed Pseudomonas aeruginosa, which was sensitive to fluoroquinolones, carbapenems, as well as piperacillin tazobactam, and ceftazidime and cefepime. And this was his chest X-ray, which showing left lower zone consolidations with ground glass densities and few pericardial effusion. So now we already started him on AKT, and he developed the deranged LFTs. So who was the culprit in that? So we all know he was started on conventional first line AKT. So what was the drug which causing his hepatic derangement? So basically, we know the four drug AKT means your rifampicin, isoniazid, pyrazinamide, and your ethambutol. So here he showed both cholestatic pattern as well as transaminitis pattern. So here the culprit could be both three drugs, that is your rifampicin and isoniazid and pyrazinamide. Basically, the rifampicin causes the cholestatic hepatic injury, while the isoniazid and pyrazinamide causes your transaminitis injury. So, what is the difference between your cholestatic injury and transaminitis injury? So, cholestatic injury is basically increased in your bilirubin as well as alkaline phosphatase relative to the enzymes, that is SGOT and SGPT. While transaminitis pattern is a vice versa, that is elevated your SGOT, SGPT relative to your alkaline phosphatase and bilirubin. And main cause of transaminitis is pattern is hepatitis, while cholestatic pattern is intrahepatic or extrahepatic injury. So we did stop his AKT and continued him on combutol, that is ethambutol and levofloxacin, which was hepatosafe drugs. So now the question is, what are the other common side effects of anti-tubercular medication? So we already seen the one, that is hepatitis is one of the common side effect. Others are rashes as well as GI disturbances such as nausea, vomiting, then visual disturbances with the ethambutol, as well as joint pains with the levofloxacin or pyrazinamide. So this is the study which showed that is drug-induced liver injury is the case, and when you have such a pattern, that is drug-induced liver injury, then you should stop your AKT. So you should stop your drugs when there is increased in your enzymes 3 times or 5 times more than your upper normal limit. And after cessation of your AKT, you can reintroduce your AKT one by one when the enzymes or a hepatic derangement is normalized. So you can reintroduce. So management of drug-induced liver injury is nothing but the reintroduction of your anti-tubercular drug after normalization of your LFTs. So we did reintroduce the did reintroduce the AKT and he tolerated it well. But later, the same patient developed headache, confusion, and blurred vision and found to have the higher BP, that is 200 by 120. So there is a gradual increase in BP as we put him on AKT. So after starting AKT, so he developed he has a blood pressure of 140 by 90, developed it to 140 by 110, then again 170 by 100, and finally on the day he had a BP or a sludge, hypertensive sludge of 200 and 120 BP. We did a CT brain which showed no significant abnormality. So in that case, what is the reason behind the increase in BP and what we should look for? So basically, the reason behind the increase in BP here is the rifampicin with the combination of nifedipine. As and we should what we should look for, the drug-drug interactions. So here the rifampicin and the nifedipine has a drug-drug interaction. As the rifampicin is a drug inducer, CYP3A inducer, it induces a nifedipine metabolism and it increases the metabolism of nifedipine, and which could not show the nifedipine action. So there is decrease in exposure of nifedipine and decrease in levels of nifedipine, which causes the less activity of nifedipine and causing into a hypertensive sludge. So here the takeaways from our case one is we should look for the common drug interactions and we should look for the common side effect. So common side effects basically are your hepatitis, transaminitis, then nausea, vomiting, visual disturbances, rashes are your common known side effect. But here not known is a hypertensive sludge. So we should look for the drug-drug interaction as well while managing the patient. So this is the study which indicate that there is a this is the study in the patients basically which are on ATT and concomitantly while on nifedipine. So there is a significant increase in BP while the patient is on rifampicin as well as concomitantly on nifedipine, and the concomitant administration of these drugs more than the 3 days can cause in a hypertensive sludge. So moving towards case 2. So case 2 is basically a 35-year male with no known comorbidities. He was a doctor by occupation and had a backache since 6 months. So he has a complaint of backache since 6 months. So investigation done outside. He was evaluated for his back pain. So MRI was done, which showed L2 L5 spondylodiscitis with disc bulges and which was likely of infective etiology. So he was done a tuberculin test, which came positive. He after that done a spinal biopsy on which the aerobic culture gene expert as well as histopath was done. Gene expert showed negative, that is negative for Mycobacterium tuberculosis. Culture was negative and histopath only showed a granulomatous inflammation. On the basis of tuberculin test and a histopath report, he was started outside on ATT. So anti-tubercular treatment was started him on outside. He was improved initially, but after 3 months again starting having the backaches. So he showed an improvement, but later on he again started having the backaches. So he came to us. After coming to us, we reviewed all his report and planned for rebiopsy him and as well as sent a Brucella immunocapture assay test. So we sent a Brucella immunocapture assay which came positive with a titer of 1 is to 640. So here the Brucella titer is different for endemic region as well as non-endemic regions. So it is positive when it is 1 is to 160 and more in endemic regions, and when it is positive when it is 1 is to 80 and above when it is in the non-endemic region. So as India is an endemic region, it is a significantly positive titer as it is more than 1 is to 160, as it is 1 is to 640. And tissue from the L3, L5 biopsy also had grown Brucella melitensis. Now, after we have confirmation on the aerobic culture as well as the Brucella immunocapture assay, we started him on anti-Brucella treatment. That is doxycycline, rifampicin, and gentamicin. That is aminoglycoside. Patient had complaint of hearing loss after starting him on anti-tubercular treatment after 4 days. So now he was started on doxycycline, rifampicin, and gentamicin, and now he is having of hearing loss. So here, who is the likely cause of his hearing loss, or what is the likely cause of his hearing loss? So as we all know, doxycycline does not cause the hearing loss significantly. Rifampicin does not cause hearing loss significantly. So here the culprit is gentamicin. So aminoglycosides have common ototoxicity and nephrotoxicity. So ototoxicity amongst the aminoglycoside is also different. So gentamicin and other aminoglycoside shows ototoxicity, but there is difference amongst them as well. So here is the table where the amikacin, tobramycin, as well as your kanamycin have the cochleotoxicity, while gentamicin and streptomycin are most vestibulotoxic drugs. So both are the inner parts of your ear, that is cochlea and a vestibule, but it shows a different toxicity mechanism. While we started him on gentamicin, and gentamicin have more vestibulotoxic effect. So we basically stopped his gentamicin and continued him for the 2 drugs of anti brucella treatment, and he done well on that. So moving towards case 3. So case 3 is basically 58-year male with Epstein anatomy of heart came with the complaints of scalp infection after a wearing of hair wig. So here is a 58-year male coming to us with a scalp infection after wearing a hair wig. So debridement was done from that infected part and sent for a histopath. When the histopath came, it showed a broad aseptate fungal hyphae with a right angle branching, and the KOH and calcofluor, which was suggestive of mucorales. So both HP as well as markers, that is KOH and calcofluors, is suggestive of mucorales, that is mucormycosis infection. We started him on antifungal treatment. That is, a drug of choice for mucormycosis is injection liposomal amphotericin B. So we started him on injection liposomal amphotericin B, and as soon as we started him on liposomal amphotericin B, it shows the increase in creatinine trend. So, on the day of starting amphotericin B, the patient's creat was normal, that is 0.8. But after starting him on liposomal amphotericin B and the creatinine, which was done after 7 days, which increased to 2.2. So, at that point, we hold the amphotericin B. And now, as we know, that is amphotericin is a nephrotoxic. So, what is the mechanism of nephrotoxicity of amphotericin? Is the first question. What measures do you take to prevent the nephrotoxicity which was caused by amphotericin? And number three, what are the other options if we have never reversal of that or there is increased in creat after stopping amphotericin B as well? So, the mechanism of basically nephrotoxicity of amphotericin B is tubular damage as well as glomerular damage. So, it directly affects your tubular cell, causing the acute tubular necrosis, as well as it constrict your vessels in a glomerulus, which causing there is decrease in a blood supply and increase in a concentration of the drug into the glomerulus, which causing your tubular necrosis as well as glomerular toxicity. Then what measures do you take to prevent that nephrotoxicity? So basically nothing but the hydration before the amphotericin B is very important. As we all know, there are different studies which are already published for a hydration of amphotericin B before hydration of with a normal saline before the administration of amphotericin B with a conventional amphotericin B. But there are 2 to 3 studies which also published for the hydration before the liposomal amphotericin B as well. There is a lesser chances of amphotericin B nephrotoxicity with the liposomal formation, but there are still chances of causing nephrotoxicity. So hydration is the basically prevention for the nephrotoxicity caused by amphotericin B. And what are the other options when you have to stop amphotericin B? In the patient, if the creatinine is goes rising up, is trending up, then you have to stop the amphotericin B and you can start the patient on posaconazole or isavuconazole. These are the true drugs which are the drug of choices after your amphotericin B for mucormycosis. So this is the study, renal impairment and amphotericin B formulations in patient with invasive fungal infection, which was published in Ishan. So basically, this paper in this paper there is a comparison between the 3 formulations of your amphotericin B, that is conventional, liposomal, and lipid complex, and nephrotoxicity with those different formulations, and how to prevent the nephrotoxicity caused by different formulations. Now moving towards case 4. So case 4 is basically a 62-year female with a known case of diabetes mellitus and was admitted with intermittent fever with a chills since 7 days. On admission, the day 1 labs and a procal and blood culture was sent. Verbal report by a microbiologist is the female's blood is growing gram-negative bacilli with a resistance markers of CTXM, NDM, and OXA48. So I'm not going to deeper into the enzymes, but as we all know, that are those are the enzymes for a resistance markers. Basically, we have to identify the what type of a bug is that, what type of resistance that bug is causing. So basically the CTXM, which is the class A ESBL, NDM is class B carbapenemase, and oxafortiase is class D carbapenemase. So there are 2 enzymes which is now contributing to the carbapenemase resistance. So we know that the whichever the bug is coming is carbapenem resistance. Hence, the patient was started on ceftazidime, avibactam, and astronome combination, as there is inclusion of three of enzymes, and sent a synergy for the same sample. So, synergy came for the gram-negative bacilli for Casavi astronome is negative. So, the synergy is negative. So, there is no use of using the combination of ceftazidime, avibactam, and astronome. Hence, we shifted the patient to the polymyxin fosfomycin combination therapy. So this is the test which showing the upper image, that is a left-sided image showing the ceftazidime avibactam astronome synergy. So one is the ceftazidime tube, one is the astronome tube, and the third tube is the combination with the ceftazidime avibactam and astronome. So both primarily are the turbid. The ceftazidime tube is turbid. The astronome tube is turbid. That means the growth is when the primarily a single drug is used, there is growth in that tube. But when it is used in combination, that is ceftazidime, avibactam, astronome, both drugs are used in combination, there is a no growth in the tube. The turbidity is not seen. So that is the sensitivity, synergy is sensitive, but in our case the synergy is negative. And the downwards image, that is right sided image, is showing your MICs of colistin by broth microdilution. So there is a tubes with a different concentration of your colistin, and we subculture the bug into the different tubes by we could identify the MICs of colistin, or we could identify the if the colistin is susceptible for that bug or not. So it is the resistance pattern of that bug. So it is resistant to all except colistin. Colistin is intermediate. So 3 days after starting a polymyxin fosfomycin combination therapy, he showing the intermittently drowsy trend. He is drowsy, moreover disoriented, and for which we did a CT brain, which was unremarkable. None of the routine medications have drug-drug interaction with the polymyxin or fosfomycin. So no drug interactions, no other causes of his drowsiness. Then what is here the cause of his drowsiness? So neurological worsening is basically due to a polymyxin itself. So polymyxin is the drug which can cause neurotoxicity as well, in the form of paresthesia, polyneuropathy, giddiness, neuromuscular blockade, as well as confusion. So there are different mechanisms of causing the polyneuropathy as well as confusion in case of polymyxin. So we contributed it to the polymyxin B and we stopped the drug. As soon as we stopped the polymyxin, within 12 hours, the patient regained his consciousness, as well as he seems to be more alert, and drowsiness improved. So polymyxin neurotoxicity is what the fourth case is. So, as we know, the our synergy is not detected, and we started him on polymyxin fosfomycin monotherapy. So, what are the other options for treating such a CRE organism? So, one we use, that is polymyxin fosfomycin monotherapy. The other options which are down the line are plazomycin, iravacycline, cefidericol, which are the newer agents but not generally used in our India, but we can use in down the line. So, and these are the guidelines basically by the in the infectious diseases journal, that is treatment options for carbapenem resistance gram negative bacteria infections. So moving toward our case 5, that is a 45-year-old male bought with the complaints of high-grade fever associated with the chills, rigors, jaundice, and itchy skin rash for 10 days. Received a dapsone for 10 days. On admission, He had a high grade fever, deep icterus, palpable lymph nodes in a cervical as well as axillary region, but without palpable liver or spleen. Then laboratory evaluation revealed the neutrophic leukocytosis with the eosinophilia as well as hepatitis. Test which was done was malaria, leptospirosis, then typhus fever, cytomegalovirus, Epstein-Barr virus. All tests came negative. So basically, the patient came to us with a high grade fever, chills, rigors, jaundice, etc. after receiving a dapsone, and we done the all test for him, which came a negative, as well as we done some immunological tests such as ANA, anti-nuclear antibodies, which also came negative. Then repeated blood and skin swab cultures were also sterile. So his CT chest, abdominal sonography, all are unremarkable. So we made a diagnosis of Dapson systemic hypersensitivity syndrome or a DRESS syndrome based on his history of taking Dapson as well as his symptoms, which was fever, skin rash, eosinophilia, etc. So, in such a cases where you have received some drug and which causes basically a hypersensitivity reaction, then what is your treatment option? Basically, he was started on then oral prednisolone 50 mg per day. From a day 6, he improved over the next 10 days with a gradual subsidence of his fever, rash, hepatitis. Antibiotics were discontinued, which was started on day 1, as it is a at after his primary presentation, he was started on antibiotics as it showed as like sepsis trend, but he was stopped on antibiotics as soon as the patient was initiated on prednisolone. So prednisolone 1 mg per kg per day was continued for a 1 month, then tapered off over a 6 weeks with a complete normalization of here liver functions, resolution of lymphadenopathy. His fevers are all gone. So here the truly case of a hypersensitivity reaction. So what are the other common medications which causes your hypersensitivity reaction? So we all know the penicillins are the one which causes the hypersensitivity reactions, but other than the penicillins, the vancomycin, sulfa drugs also causes the hypersensitivity reactions. Here the dapsone is the sulfa drug which causes him the hypersensitivity reaction. So the case 5 is all about the hypersensitivity reaction. Now moving towards our last case, that is 76-year male with a newly detected diabetes mellitus, not on any treatment, and had a infrascapular swelling since 1 month. His MRI suggestive of spondylodiscitis involving D2 to D7 level with associated posterior right paraspinal abscesses, which was adjacent posterior lateral chest wall with a large left psoas abscesses, acute SDK involving L1, L3 vertebra as well. So he was underwent the USG of local part, and the aspirate was tapped, or his aspiration of abscess were done with the USG guided procedure. Then the aspiration was sent for different tests for aerobic culture, gene expert, AFB culture, as well as staining, from which the aerobic culture showed no growth, but the gene expert for MTB was detected, and RIF resistance, that is rifampicin resistance, was not detected. And the later 1 month, the culture came positive, that is AFB culture came positive, which showed the pan-sensitive MTB, that is sensitive to your all first-line drugs. So we started him on weight-based AKT, of course, first-line weight-based AKT, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. But he developed a skin rashes and itching after 1 week of starting AKT. So we stopped all 4 drugs. So all 4 drugs, that is first-line AKT, was stopped. So we could not find out at the first who is the culprit of his rashes or the hypersensitivity reaction or the itchiness caused by the first line AKT. Who's the main culprit amongst the four drugs? Here the two papers which supported that there is a cutaneous adverse effect or a rashes or itching by the first line AKT, and which could be any drug from first line which can cause your itching or rashes or cutaneous side effects. So we can't contribute to one drug, as we can try out the error and omit an error basis or trial or error basis pattern. So he showed to the dermatologist, and dermatologist accounted it as a generalized discoid osteotosis like rash. A few lesions are like the erythema multiforma, but the other rash is like a drug induced rash. So advised him atarax and plan to add steroids if there is no improvement on antihistaminic drugs. So we stopped firstly his all AKT drug, and we started him on combutol and levoflox. So we advised to follow up after 3 days if he has tolerated the both two drugs. But again, he developed a skin rash and a swelling. So, after stopping all four drugs, he was now only on two drugs, that is ethambutol and levoflox. Still, he developed a rash. Still he developed a rash, and after adding a rifampicin, the rash worsened. So we stopped again all the drugs. We stopped INH, we stopped combutol, and we stopped rifampicin as well. So we again reinitiated him with the rifampicin and a PZA, but still the condition was same. So we stopped all the four drug AKT. We tried all the combinations of first line to him, like switching to the other drug, like stopping and reinitiating, but none of the first line AKT worked on him. So we just stopped all the first line four drug of AKT and started him on second line drugs, that is started him on ferropenam and ethionamide. He tolerated both the drugs well. After the 10 days or 2 weeks of ferropenam and ethionamide, we added a linezolid as a third drug to him. But after adding the linezolid, he developed a psoriasis. Hence, we stopped the linezolid and added a cyclosporin along with vitamin B6, that is B long. So he tolerated a three drug AKT with ferropenam, ethionamide, and cyclosporin in his regimen, and we continued him on only three drug AKT for the resolution until the resolution of AKT, and we still continued him on that. So minimum 1 month, 1 year of AKT is confirmed for this patient, as there is no first line AKT drug in his. There is sensitivity or culture proved MTB sensitive, pan sensitive MTB. Still, we could not use the first line AKT in few patients. So this is the one example of patient in which there is a pan sensitive MTB grown in culture. Still, we could not use the first line AKT drugs, and we can shift to the another drugs, that is second line AKT, due to intolerance of AKT or a side effect of AKT. So in these cases or in such a cases, we could continued the patient on a second line ATT for as much as we could give. That is 1 year of minimum treatment for spondylodiscitis. And as there is no first line AKT drug or a no sidal drug in his AKT, so we should continue at least to the 18 months of AKT. So what are the key points or what are the takeaways from our today's presentation? So basically, the common side effect of medications, that is any antibiotic, any antitubercular drug, any antifungal drug, the common side effects that we know already, we should look for the common side effects. We should know the managing strategies for common side effects. As we know, The AKTs have common side effect of rashes as well as hepatitis, as well as nausea, vomiting, GI disturbances, visual disturbances. So we should know how to manage such a common side effect. Then we should look for a uncommon side effects. For that, we should not neglect the patient history. We should not neglect the patient's complaints. So whichever complaint the patient is saying, we should hear the patient properly, because the history taking and the patient's complaint are the key points which lead you to your suspicion of the side effect as well as the management of those side effects. So patient complaints as well as the patient history or a medication history are the key points or the crucial points in your identification and managing of a side effects. Number three, counseling of the patient is an essential part when it comes to the side effect. So whenever you are giving a patient a drug with a known side effect such as amphotericin B or a polymyxin, that you know that amphotericin have a nephrotoxicity, so you should counsel the patient properly that you are giving a drug which can cause the toxicity or causes the harm to the part of their system or a part of their body. Then you should know what are the prevention you are going to take for that, and you should have explained the patient well that you are going to give such a drug because it is important, but you are going to take the prevention for that. And the correlation with the lab parameters, as we seen in the many cases, there are increased in LFTs, increased in creatinine, increased in different levels, that are your lab parameters. So the correlation with the lab parameters is very important when there is identification of side effects. So when there is increased in slight levels of your enzymes in LFTs, or there is increase in slight creatinine, so there is nothing related to a toxicity when there is in a normal range. So you should know the lab ranges when it is in a toxic level, when it is in a normal level, when it is in a below normal level. So those are the key takeaways from my presentation today. Thank you so much, and thank you for the opportunity, Epsifia.
That was a very comprehensive case-based approach to clinically significant adverse drug reactions of antimicrobials. So, Dr. Surabhi, thank you so much once again. And let me raise a query. Like,
Yeah.
so you have discussed about, what to be done before giving an antimicrobial, which is, prone to cause an adverse drug reaction, how to correlate with lab while patient is on stay, and like how to, manage the condition also.
Yeah.
So, what's your take on for like how do we document this clinically significant or non-significant reaction in our medical records, and do we need a surveillance system? Is it that required, like kind of like we update MDRs? Is that required? You know, for the part of documentation part, how shall we do that? Do you
Yeah,
have any?
basically, yeah. So ADR documentation is as well as important, as we know that the ADR finding, that is identification of ADR is important. With that, the ADR managing and ADR documentation as well as is important. So we document the ADR to the PCPI. So basically, we should document that ADR. So every hospital does have the forms of ADR documentation. We should document the ADR, and we should provide it to the PCPI for that.
Okay. Do we
Yeah.
need to document this adverse drug reaction in medical records? Because when it comes
Yeah.
to patient care, like medical insurance company may sometimes
Yeah.
have a hard eye on us. So how do you want to comment on that?
So yeah, it is
I know it's
important.
very tough to answer because we
Yeah.
find it's very difficult to document this sad truth. though it's
Yeah,
true.
true. Yeah, because I am not basically come into such cases like when it is come to the departments, or but we should record it medically, and we should keep the records in our hospital for that purpose also.
Okay.
Yeah.
Okay, thank you, Dr. Surabhi. Thank you so much for the presentation, for answering the query so well. So, dear participants, thank you for watching, and let's catch up with another session. Thank you.
Yeah, thank you so much.